Good afternoon, everybody. So thank you for coming. For those of you who I haven't met, my name is Mike Clegg. I'm the current dean of the Bloomberg School of Public Health. And about 3 years ago, we started to do this, where we would start the school year with a conversation with the dean, with three deans, and somebody in external affairs named it "We Three Deans," and so I have the gold, right, you have the frankincense. Yeah. Thank you, Sir George, wherever you are. So, and it's a different topic every year, but it's a conversation with us, and it's a way too for those people who are new to the school to get to meet the Dean Emerita. Emeriti, I guess. And so we're going to, and the topic this year is the next big thing in public health. Now, I have to say, we have nothing to do with this topic, that somebody, Rachel Hamrock or somebody, assigns us this topic, but that's the topic. And I'm happy it's not healthcare reform. That's all I can say. So we're going to go in order of seniority. So the first speaker is going to be D.A. Henderson. And D.A. was dean from 1990 back to from 1978 or so, 77. And I think D.A. is a person who needs no introduction. But for those of you who have been living under a rock, I'll tell you a little bit about D.A. D.A. trained in medicine and then received his MPH degree and went to work first for the CDC, setting up surveillance and demonstrating the power of epidemiologic surveillance, and then was involved, led the smallpox eradication campaign. First was seconded from CDC to WHO, and then led the global effort. And it's the only time, as we all know, that the disease has been eradicated. And D.A., just as that program was winding down, came to be dean at our school, where he oversaw a modernization of procedures and policies and an increase in the rigor of the academic activities here at the school. And also for new students, you may not know, but D.A. wrote a book last year called Smallpox, Death of a Disease, which is, I think, required reading for anybody in public health. So our first speaker to talk about the next big thing is D.A. Henderson. D.A.
Well, let me say it's very good to be back again, and I think I've told many of you before or advised you as to what I learned from the experience in smallpox, and which I think is an important lesson for you. And that is to choose your specialty with care. I wound up at 1977 as a world expert in smallpox. The only trouble was there were no more cases. And there you are without any marketable skills. What do? Well, I became a dean. But I commend your courage for coming to hear not one, not two, but three deans. That's a bit much. And I thought for a while, what possibly could I say? And with 20 minutes and to talk about this particular topic, which is really a difficult one. And I thought, well, if it's an hour-long affair that I had, that I had an hour, that wouldn't be too difficult. As a dean, the one thing you learn to do is speak at length with minimal notes and probably not too much substance. But for 20 minutes, it had to be something a little more substantive. And so for the first time, I think, in 20 years, I've actually put together a speech that actually I can read. My secretary thinks I've lost my mind. My wife can't believe it. But there were some important things that I did want to say, and I thought this would keep me within bounds and perhaps would be of interest to all of you. Today we take many things for granted. We forget that at an earlier time, a time well within the memory of my parents and myself, that attitudes and expectations were vastly different than they are now. We take for granted that potable water will flow from the tap. and we can trust the drugs we purchase when we go to the pharmacy. That the outcome of a pregnancy will almost always result in a healthy mother and baby. And that families can decide for themselves how many children they can nurture to adulthood. And we have every reason to be optimistic about a brighter world, no question about it. But it's very critical that we not forget a not too distant past and the efforts that were needed to effect the changes that we have. Water quality standards must be constantly policed, and those who are polluting it have got to be stopped. Opponents of fluoridation and milk pasteurization still exist and still argue the case that we shouldn't fluoridate water or pasteurize milk, and they have to be regularly educated. And today there are as well, in a likely situation, those who would have us return to a sort of late Victorian era when sex education was unknown and contraceptive devices and abortions were illegal under any circumstances. We forget that this was a reality in our own country, and not that many years ago. It is a reality today in many parts of the world, and we need to be regularly reminded of this. For those of us in the smallpox program, it was immensely gratifying to witness the steady decline of cases of this ugly, painful, and fatal disease. But one could never ignore an ever-present mass of ill-fed, uneducated children with little access to medical care, surviving in families that could not provide even minimal shelter, and gangs of children who knew no parents at all. The pictures from Haiti express a part of this very sad panorama, which is all too common today. A meaningful, poignant phrase to me has been, quote, the tyranny of excessive, unwanted fertility. During the latter part of the 20th century, family planning services were gradually expanding and encouraging progress was being made, and then came the dark ages of the past decade. It has seemed to me that discussion has been muted about the urgent needs for support, let alone growth, of family planning, of reproductive health, and even of the rights of women. This has abruptly changed with the election of President Obama. And for this we should be very grateful. I certainly am. But lest we forget, I would propose to go back to an earlier time in this country so that we may appreciate how thin is this veneer of change, how recent it was that unbelievably conservative policies pervaded the country. I go back to 1937, the year I was born, or 1927, the year I was born. And that year, a meeting was convened in the office of Dr. William Howell, who was then dean of this school, and 3 other Hopkins faculty. And the reason was to form a Baltimore Committee for Contraceptive Information, to provide a place where contraceptive advice and supplies could be provided, the only place in the city. For 50 years, federal law held that it was illegal to sell contraceptive devices or to distribute information on abortion. The post office was ordered to confiscate any mail containing material relating to sex education or contraception, or which was intended for other indecent or immoral purposes. And the postal inspectors were empowered to prosecute the sender and the recipient. Our Hopkins trustees refused to house such a controversial clinic. And so the committee, with other Baltimore leaders, established a privately funded facility at 1028 North Broadway in a house directed by a recent Hopkins medical graduate, Dr. Bessie Moses. But they did so only after visiting the Maryland State Attorney Office and getting a promise that he would not interfere with what was a law-breaking activity. The clinic accepted only married women as patients, and they had to be referred to the clinic by physicians. And the women could only be seen if, because of mental or physical health, pregnancy had to be avoided. Records show that among the first 1,150 patients, they reported 1,000 abortions. Some had as many as 10 or 15 that had, and of the group that bore 5 children and they had 1 woman had borne 26. The clinic grew and gradually expanded to provide a range of reproductive health services. It was the beginning of Planned Parenthood of Maryland. Not until 1936, did the government agree to stop interfering with physicians distributing contraceptives. It's not that long ago. Not until 1965 were until 1965, mail deliveries remained subject to confiscation. When I was growing up, contraceptives were available if prescribed by a physician. Sex education was essentially nil. Condoms were a taboo subject, and a number of states banned or restricted abortions. My own involvement with the question of abortion occurred during my residency in internal medicine in upstate New York. During the period 1957-59, we regularly saw young, unmarried women who were pregnant and sought help. Especially in a closely knit rural society, the stigma of birth outside of wedlock was devastating. Many of the women were essentially ostracized from family and community, and the families themselves emotionally devastated. In urban areas, unmarried mothers-to-be were often secretly sent to special resident homes until a baby had been born and adopted. The alternative was an illegal abortion. For the young women and their families, the decisions were agonizing. Every one of these cases was, for each of us, a searing experience, and it haunts me even today. In 1973, the case of Roe v. Wade was brought to the Supreme Court, and among other determinations, the court recognized that it was a woman's right to decide whether or not she wanted to carry a pregnancy beyond the second trimester. It permitted a considered decision to be reached, balancing abortion against another, an often destructive outcome, not only for the woman, but the entire family. But as you know, overturning this decision is now a central objective of one of our political parties. An increasingly educated, more sophisticated population seemingly should progress unabated toward equity and a full recognition of women's rights. Instead, the past decade has witnessed the emergence of a conservative orthodoxy that has threatened to turn the clock back many decades. Federal funds for domestic family planning services all but disappeared. So-called pro-life groups fought to have abortion services terminated altogether. Family planning clinics have been attacked, and physicians providing abortion services, as you know, have been murdered. Stem cell research was seriously stunted, and the abortion views of candidate federal judges became a litmus test for appointment. It has troubled me, and in fact, that the phrase family planning has become increasingly scarce. The effect on the international scene was especially damaging. U.S. foreign assistance funds could be provided to any organization, could not be provided to any organization if it simply advised or counseled about abortion. The multi-billion-dollar AIDS program, which the U.S. has been active on, was severely constrained. Half of the funds were earmarked to promote abstinence education, no program of which showed any benefit whatsoever. None of the money could be used to promote the use of condoms, even though their use was an important component of AIDS prevention strategy. No funds whatsoever were provided to the United Nations Population Fund. So January 2008 has brought a new administration. It reminded us of commitments, which I quote from the 1995 International Conference on Population and Development, which Secretary Clinton spoke on just in the past week. That reproductive health care is critical to the health of women, that women's health is essential to the prosperity of all, to the stability of families and communities, and the sustainability and development of nations. This is from the 1995 International Conference. And the conference resolved that all governments must make access to reproductive health care and family planning services a basic right, and that the doors of education must be opened to all citizens, especially girls and women. Impediments remain, however. In this country, in particular, there remains a cadre who will not be content without a return to the world of the early 1920s, when all abortions were illegal and when it was impossible to purchase contraceptives. Underlying the veneer is the fact that many in this male-dominated cadre fear being challenged by women who have rightfully sought and have succeeded as judges, senators, university presidents, scientists, ministers, and even as deans. But lest we forget, the progress we have made took both work and courage, and more is needed if this is to be sustained. Thank you.
Thanks. So maybe sit down there and then we'll come up. Good. Thank you, DA. You know, some of us were in Uganda for a conference that was supported by Amy Choi and the Gates Reproductive Health Institute in November on family planning, and it was the first international conference in 15 years. And it was and you could have been the keynote speaker there. So thank you. What we're going to do is I'm going to ask our next speaker to come up, and then when he's done, I'll say a few words, and then we'll sit up here. So and we'll have some Q&A. So our next speaker is probably also somebody everybody knows, Al Sommer. And Al was my predecessor as dean. He was dean for 15 years, from 1990 to 2005. And much of what you see about you is a result of his success as a dean, especially this portrait of him over here. But I think everybody knows that Al oversaw the build out of the master plan for this campus, which DA had caused to be done in the early 80s. But many of us don't know on this side of the street that he's really led a double life. So we know him as the person who has been a leader in research in child survival and clinical trials of micronutrient supplementation to improve health and reduce mortality in children. But he's also been a clinical ophthalmologist who has really changed the paradigm for how ophthalmologists think about treating disease and detecting the disease. So he could be giving a very different talk if he were on the other side of the street. But Al has won the Lasker Prize, which is often called the American Nobel, for his work in vitamin A supplementation. Now chairs that board and oversees the work of the Lasker Foundation. Al, I think, more than anybody I know, is the most articulate spokesman for what public health is and in explaining what we do to people who don't understand public health. I feel good about being dean because when I look at our emeriti deans, I think, wow, I'm going to be pretty good. If I can be these guys when I'm 65 or whatever, I'll be happy. So Al, our next speaker, Al Sommer, on the next big thing in public health. So.
Thanks, Mike. It's always a little bit intimidating to speak under that portrait. And the last time I did, which was only a couple of weeks ago, Jim Tilch was quick to come up and say, "Don't you have another pair of clothes?" Because without knowing, I was wearing the same tie, the same suit, and the same. So I'm wearing a gray suit today, Jim, so you can, and a different tie. This also shows that if you just take two deans or dean emeriti and just give them a simple assignment, what's the next big thing in public health, they'll come up with totally different stuff. So DA and I and Mike didn't practice beforehand, so my comments will be a little bit different. So as you all know now, the title that we were assigned, or the job that we were assigned, was what's the next big thing in public health? And by definition, I have absolutely no idea. Because if I knew what the next big thing would be, the next big thing would be, I would be both rich and a savant. Now, that doesn't mean I am without some suggestions. So, if you really want to know what a next big thing will be, as the saying goes, you create it. So we'll give you a few examples, at least from my career in doing that. When Henry Moseley and I were living in what was then East Pakistan, and there was this horrendous cyclone disaster, with at least as many deaths, if not more, than have happened in Haiti. 250,000 people washed out one night. The Pakistan government came to the American ambassador and asked for a dozen field hospitals and 20 or 30 x-ray machines, a variety of other equipment. And we asked the question, well, do we need that? I mean, it sounds like maybe lots of people were washed away, but it's not clear that there's a lot of trauma, and we need a lot of trauma stuff. So we carried out first a very quick survey by helicopter, and then a more extensive survey, more geared towards rehabilitation, using ferry boats and so forth. And just a few of the things, we could identify exactly where the biggest hit areas were. These are areas that had greater than 20% mortality rates. This is down in the Bay of Bengal. This is the mortality curve. So you can see, like in the Titanic, women and children do go first, but they go first to their death than anybody else. So it's the young and the aged and females more than males that have the mortality. And this whole thing actually was the beginning of what is now an entirely independent discipline of disaster epidemiology, of which we have so much going on here at the school. Now that led to another related activity. In carrying out the larger survey, I felt I needed some mechanism by which to identify which populations were most in need of food relief, and then within that populations perhaps which children and individuals were in greatest need of food. The trouble is that there was no, in fact, simple tool for doing this. And we had recently read about a technique that was described by the Quaker groups that was working in the Biafran war, where there was a lot of malnutrition, and it basically came down to using arm circumference, but no data to indicate how well that did in discriminating between individuals and populations and what their needs might be. And just a quick rundown. So what we did was measured a bunch of children in Matlab, an area that was not affected by the cyclone disaster, and took first the bottom 8th percentile and called that category 1, and then up to the 50th percentile was category 2, and then up to the 100th percentile in terms of the thickness of their arms was category 3. And then I was 18 months later, which followed not only the cyclone disaster, but a civil war and a smallpox epidemic and lots of other things, go back and see what happened to the children that we had characterized 18 months earlier. And what this shows is that within the first month after characterization, the children in that bottom 8th percentile were responsible for 56% of all the deaths, and had 20 times the mortality rate of the children in the upper 50th percentile. And then as you go out in time, of course, children die. They migrate between nutritional categories you don't know. So between the first and third month, these original bottom 8th percentile were still dying at 12 times the rate of the children who were in the best group. So now the arm circumference is the standard way that people do anthropometric measurements around the world, but this was the first study that actually demonstrated its ability to discriminate between a children's nutritional status by a very simple method and their risk of dying. And some of you have heard me give the lecture before. It was almost impossible to get this published because it would always get sent to nutritionists, and they couldn't understand why mortality was an important outcome. I mean, they thought, well, you know, if you really want to prove this is useful, you ought to do arm circumference versus, you know, toenail length or head circumference or something. They couldn't quite get their arms around, so to speak. So speaking, and in fact, it was picked up. The only reason it became popular was it was picked up 2 years later by WHO. They had an expert group on nutritional surveillance, which then was becoming a new buzzword. And in there they said there's been no data whatsoever to tell us how to go about doing nutritional surveillance except for this one publication. And then there's been, of course, a raft. And this is another area now that is a major discipline in its own right. So thank you, Mike, for giving me the across the street ability to say something. So I was a resident at the time at Wilmer in ophthalmology when a very famous neuro-ophthalmologist on the West Coast, looking at the back of the eye, said, you know, there are these funny-looking nerve fiber dropouts, and I think this is a good way to diagnose glaucoma. And the entire publication consisted of a single letter to the editor of Lancet in order to be able to get priority for that observation, which was important enough. And then he went around and tried to convince his fellows and so forth that this was important, but nobody actually studied it. And there I was as a resident, and I had discovered a treasure trove of photos of the back of the eye of people who were at increased risk because they had high intraocular pressure of glaucoma, and their spouses who served as controls that had been collected over the course of 10 years. So I had longitudinal photographs on the same people, some of whom developed glaucoma, as it is defined by a demonstrable change in the visual field, and many of whom who didn't. So I took Neil Miller, who was an acolyte of Hoyt's, and I gave him, I didn't want him to have to look at thousands of slides, but I took serial ones of the people who actually did convert to glaucoma, mixed those all up, so he had no idea what order they were in, and mixed those up with controls and blackened out the disc so you couldn't get any other clues other than looking at the nerve fiber later. And I said, you come back and tell me which one of these have glaucoma. So this is what, disregard that, that's a little hemorrhage on a disc. This is a little bit hard to see because the original photos weren't taken for this purpose. We now have special techniques for that. But you can see how this is darker than this and this over here. So this is nerve fiber layer loss here. And Neil came back with his results, and I plotted them, and this is what we had. At 6 years before a diagnosis of glaucoma was made, you could find, he was able to identify, not knowing that this was 6 years before, a defect in over half the people who were en route to having glaucoma with a specificity of almost 90%. And at the time they developed a glaucoma over here, almost 100% could be identified by simply looking at the back of the eye. And then that was the basis for, after I then went out to Indonesia and came back to Hopkins, for my first NIH grant. We recruited a large number of people to actually follow them prospectively. Joanne and Jim, who are in the audience, were involved in that. And this was the first go at them, and it shows that this is, at the time the visual fields became abnormal, a pretty good sensitivity and specificity. Now, in fact, there are 3 commercial machines on the market that do this. I have no financial interest, unfortunately, in any of them. So this is sort of now the de rigueur way to go about making an early diagnosis of glaucoma. And just for fun, my secretary, Rebecca, went online the other day and looked up for just things that had nerve fiber layer in the title. So here's sort of nothing. Here was that first observation paper, another paper that was hard to get published. Here was a 1984 paper. We got another Leptuck. And here was our third paper on the subject of this group that we were following. You can see how it's just taken off since then. So if you invent it, it will come. And of course, I'm not going to bore you with the vitamin A story all over again, other than to point out before we made this observation, people didn't much care. We made this observation. People still didn't much care. because they didn't believe it, and then we were involved in either doing or instigating a whole bunch of these randomized trials, which ended up with showing that on average you got about a 34% reduction in childhood mortality by giving out a vitamin A capsule 2 or 3 times a year to children. And so again, we sort of changed the paradigm, if you will, and now, of course, vitamin A supplementation is a global program carried out in 70 countries. Is one of the metrics that's used by UNICEF in the State of the World's Children report each year. So these examples were all products of unique opportunities provided by a unique set of circumstances for me at a specific moment of time. So then one next big thing has got to be straightening out the mess that is healthcare reform. I mean, if you look around and say, you know, I don't know what the big thing will be, but one big thing that is huge and is sort of right on top of us is this. And it's suggested by the circumstances at this moment in time and something that needs to be taken care of. Now, a number of you will have seen this. This was one of those slides that Mike suggested I used to use to try and get people to understand the difference between medicine and schools of medicine and public health and schools of public health. So this is the population, and the population has this one red person over here. And who is this red person? This red person is somebody who is sick, knows they're sick, has access to care, and is getting care. That's medicine. So what's public health involved with? Well, we care about this red person also. You just think about the things we worry about. Is the care they're getting effective? Do the treatments work or don't they work? How much do they cost? The whole thing that Pina Pronovost does about errors and quality and what have you. So we care about this person too. But we also care about all these other people. So who are all these other people? Well, some of them are sick, know they're sick, and they don't have access to care. That concerns us a great deal. Some of them are sick and don't know that they're sick, and that's why we're concerned with screening techniques and outreach to the community and what have you. And then hopefully the largest group, like hopefully most of us today, we're not sick, but if we don't do certain things and live life in certain ways, we will get sick. So this, we're really concerned about the whole totality of what's going on here. And only public health can take this on. Because every other group, whether they're surgeons, politicians, hospitals, or drug companies, are riddled with conflict. And they don't have the overarching perspective that we in public health bring to this. And just to see just 2 small examples that goes beyond the stuff that's going on the Hill is, you've all seen this recent disaster about trying to be thoughtful about mammography. Well, this is a replay of exactly the same thing that happened in 1997. Expert committee, in that instance, chaired by Leon Gordis, who had been chairman, as you know, of our Department of Epidemiology. An expert committee appointed by the then director of the National Cancer Institute came out with exactly the same recommendations, and within picoseconds of the press conference, the director of NCI denounced the recommendations of the expert committee. So we've been there before. We can't deal with that. And now we're going to cancel all the vaccine that we have ordered. I don't know what pharmaceutical companies are going to think about the next time we tell them to drop everything and get ready for an emergency and a pandemic. So who but public health can design an integrated approach that runs fluidly from preserving health to preventing and treating disease while not going broke in the process? Who can help figure out what we do about too few kinds of physicians and health workers and where we need them? Too little incentive and promotion of healthy lifestyles or focus on evidence-based for healthy living and treatment? Breadth of expertise for dealing with ethical and financial tensions involved in addressing cost effectiveness so that the health expenditures don't break the bank? Choosing the value proposition in conflict with the prevailing everything people want whenever they want it, if they can afford it, with a bottom line focus on the ultimate impact of the health and well-being on the community and not just anecdotal success rates of what's happened to individuals. Thank you very much.
Well, thank you, Al. I mentioned that DA authored a book, Smallpox, Death of a Disease, and Al also this year came out with a book about healthcare reform and of other topics called Getting What We Deserve. Now, I haven't written a book, but I do have the cover story in the Gazette. In the Gazette, I am the cover story, and they asked me what the big things were in public health, so I actually scooped our talk by. So you can read that interview if you want to know what I think. But I'll just comment briefly because I want to have Q&A. And I have to agree with DA. I think if you look at what's the big elephant in the room about public health, it's population growth. Right? If you look at all the things we worry about in public health, I think population growth underlies many of them. Right? So climate change and the effect on health, clearly something we have to do more on. But what's driving that in large part is population growth. If you look at water, DA talked about water. Clearly, access to safe water, emerging contaminants in water are big issues, but population growth is driving that. Disaster response, death from disasters. We have people living in areas now where they've never lived before, areas where they wouldn't live before. And clearly, population growth, there's an exponential rise in death from disasters. Some of that's due to climate change, but some is due to the fact that we just have more people. Urbanization and the rapid urbanization that we're seeing. Population growth is big. I think empowerment of women, that's a huge issue for us. The growth, the unmet need in family planning services is the mirror image of that women aren't empowered to make decisions about themselves. So I think population growth is key. But I'll say one thing that I haven't heard mentioned, and that's chronic disease. Now, I hope Diane Griffin isn't in the room, because whenever I talk about chronic disease, she always sits in the back and says, well, infectious diseases aren't going away. That's true. We know in the next 10 years we're going to have new diseases that we haven't seen, zoonotic diseases that have moved from animals to people. Population growth is a big reason for that. We know that there's going to be another pandemic, right? We know that on average every 30 years there's a flu pandemic. We're going to see other diseases emerge. So all those issues that we deal with, maternal mortality, child mortality, infectious diseases, they're not going away. But what's coming on strong is chronic disease. So it's the leading, if you look at non-communicable diseases, it's the leading cause of death in the world. Somewhere, I don't know, about 20 million people a year are dying. Look at India, 12% of that population, which is a young population, has diabetes. They have high rates of malnutrition, undernutrition, but they also have overnutrition. And it's a sad paradox that those countries that have the highest mortality from maternal mortality, childhood mortality, diseases related to infection, also have the highest mortality from chronic diseases. We think of chronic disease as being an American disease or the developed world, but in fact, the rates are very high in the developing world as well. So I'll just mention chronic diseases. It's an issue that our school has led on, right? If you look at Abe Lilienfeld and what he did, and George Comstock, they helped us move epidemiology and the science of prevention from just infectious diseases and nutrition to chronic diseases. And George always said that TB was a great paradigm for that, because TB, such a long, quote, incubation period, it's like a chronic disease. So if I think about the next big thing, it's not the next big thing, it's here, it's chronic disease. And how do we take the science of prevention and public health and apply that better to chronic disease? And Al talked about paradigm shifts in talking about glaucoma. And those of you who have been here when I've spoken and welcomed students to the school, I always talk about that in education and public health, it creates a paradigm shift for us. It's a transformative experience where we stop, as clinicians especially, stop looking at cure alone and look at prevention. And that's the shift that really has to happen more in chronic disease than it has. So we need more effective lifestyle interventions. We need to figure out how you talk about the conflict of interest that when we deal about health care. Well, what about food? And we know in this society that we don't eat in a healthy way, but it's very difficult to buy food that is healthy. So we need to take that that ability to change societies, as we have done with TB, as we've done with maternal mortality, although there's still room, as we've done with childhood mortality, and apply that to chronic disease, the way we eat and the way we live. Now, so again, it's a little specious to say that's the next big thing, because all these things are here, right? But clearly, as a school and as a discipline, we need to continue to do everything we're doing and more, and especially focus on chronic disease.